Oneness is the answer, and its time is coming. Another day is here, and it's a time for healing. Look around the world and see our families dying. Doesn't seem to matter all the things we're trying. Another needle in the arm is just a message. Another day is coming, and it's time for healing.
My name is Bob Pura, and it is truly my privilege to be president here at Greenfield Community College and to welcome you all. There was something different in his voice when John Merrigan called me about 10 months ago to tell me about the heroin problem in our community. Now, many in this room have received a call from John over the years about this event or that issue, but there really was something different in his voice this time, something more compelling, more heartfelt. John was making the calls now because of his depth of understanding and his deep concern for others in this community. Ladies and gentlemen, can you please join me in thanking John Merrigan and the entire Merrigan family for caring so deeply and honestly about this issue, and for the leadership John has brought in moving this community to address our opiate addiction crisis. John? But John did not do all of this alone. Chris Donnellan and Dave Sullivan worked tirelessly with John to create the task force and to get the entire community engaged. And though I will be more formally introducing Sheriff Donnellan in just a moment, I thought that you would like to thank both Chris and David collectively. So Chris, David, if we could thank you as well. Speaking of this community's awareness and engagement, I do want to extend a special thanks on behalf of the task force to Chris Curtis and the recorder. They have placed this issue front and center, and the task force appreciates their effort. Also here are our local delegation that I would like to bring your attention to. Everyone in this room knows just how smart and hardworking our delegation is, and we would not be in this room together were it not for their support. We would not be able to achieve the goals that we will set forward from this moment forward without their support. So I'd like to begin by thanking Representative Paul Mark, Representative Denise Andrews. Paul Dunphy is here representing Representative Kulik, who is on his way. So, Paul, if you would. Senator Rosenberg will be introduced in a moment as a speaker, and Natalie Blais, who is here momentarily representing Congressman McGovern, who is also on his way here to give his remarks. Our community has a problem. You are here because you get that. You're here to learn, to engage, to help our community figure it out. And we will figure it out. We will because you are here. That's how that works. There is no problem that we as a community, given the expertise, given the passion, given the energy, given the engagement, and given the resources, that we together can't figure it out. And in this room, we will find all of the above. The disease that brings us together does not discriminate based on class, race, gender, or religion, but you all know that. The disease that brings us together today is deadly, all too deadly, but you know that too. This disease is extremely expensive with regard to the toll it takes on families, to society, to our community, and it has no easy, quick solutions. Our courts and justice system are part of the solution, and so too is the state, healthcare, and education. Ultimately, and in the final analysis, our community problem will be resolved by our community. To that conversation and to that work, on behalf of the task force, our students, faculty, and staff, I want to welcome you to the first annual Opiate Awareness and Education Task Force Conference. It is now truly a pleasure to introduce Dr. Ruth Pote. Ruth is not here today because she is out of state. And you could read a more extensive biography of her in your handout. Today's conversation would not be as strong without her words, her voice, and vision. Dr. Pote is that rare balance of seeing things from the 30,000-foot level, but also able to engage with her patients and their families in her office and in the trenches in this community on a daily basis. Having grown up in this community, she has returned to practice medicine, has become a leader here in the treatment of the addicted, as well as in the development of our community response to this crisis. Ladies and gentlemen, Dr. Ruth Pote. Gary, if you will.
I just wanted to be able to add a medical perspective to the conversation in this room. I trained actually in South Boston, and I trained at the old Boston City Hospital, Boston Medical Center in the 1990s, and watched the opiate epidemic really hit Boston in the 1990s. And at the time, it was the beginning of the notion that pain is the fifth vital sign and that pain should be treated at the highest level possible until pain is disappeared. What we know, and we knew then, and we certainly know now, is that's certainly not possible, and that the opiate use over time can develop into addictive behaviors for many people. So my dad was a small town doctor out here. I'm from here. He was a local doctor at a local hospital, and he never used opiate pain medicine unless somebody was dying, and that's the way it was. It was that way in the 60s and the 70s and the 80s, and it wasn't until the mid to late 90s that we began to use opiates to help treat all kinds of conditions: fibromyalgia, migraines, arthritis, low back pain. And many of us on that list I just named have those conditions, and the standard of care had become that if people walk in with pain, you give them opiates. The sense that we were all given is only 5% of people would get addicted to these drugs, and most of us think that number is totally not right. Probably the number is closer to 25% of people are actually addicted to their pain medicine. I don't mean dependent. 100% of people who are using opiates chronically are dependent on that drug. They will withdraw if not getting it. But I think the number is 20 to 25% who are actually addicted to that drug. The study that really promoted pain as the fifth vital sign was based on 39 patients. And I think at the end of the day, Big Pharma was the major big push behind this. The best studies look at fewer than 500 patients over a period of 8 months. So that is pathetic in terms of medical science. There are 10 million Americans living with chronic pain, and I'm basing all my opiate treatment on less than 500 patients. That's crazy. So more studies need to be done looking at what opiates do to people long term. At this point, long-term opiate use in people in general leads to underemployment and disability. It's never clear to me why this is the case, but we're working on 3 or 4-year-old Department of Public Health data. So every number you see out there is 2010 or 2011 or 2012. I guarantee you that things are much worse than they were in 2010, 2011, and 2012. At the time that I was working at the South Boston Community Health Center on West Broadway Street in South Boston, OxyContin had really hit the streets. We were prescribing it a lot. We had been told by Purdue Pharma that it was a drug that was long-acting and not abusable. It was very fast for people who wanted to get high, for them to realize that if you crushed that pill, if you snorted it, if you crushed it and swallowed it, if you crushed it and injected it, it was a fabulous high. It was a high as good as many typical heroin on the streets. So people began abusing that drug. I think we all remember the time of OxyContin being abused throughout the entire Northeast corridor. So more of us are seeing this way in the medical community. We're less comfortable with using opiates for any reason. We're tightly controlling how we dispense. We're asking people to come in and be evaluated far more frequently. We do urine drug screening to make sure that people are using the drugs we give them and not using illicit street drugs. It's one of the reasons why pills on the street have become more scarce and more expensive. It's a good thing. The unintended consequence has been that heroin is cheap and deadly. But it's a good thing that pills are less available. We're also urging our patients for whom we do prescribe pain meds to lock them up at all times. You should have a lockbox that's bolted down and that is really as tamper resistant as possible. A safe is a good idea. We ask people to keep logbooks of their pills to make sure that their kids aren't accessing them. So those are things that we used to never talk about with our patients, and now we talk about routinely. It's standard screening when a chronic pain patient comes in to make sure that only they are getting their meds and nobody else, and that they're keeping their community safe. And in fact, if a patient is not able to keep the community safe from their pain pills, their meds are getting stolen, we'll stop prescribing for them. And if opiates are dragging them down, we need to wean them off. We discuss that with people all the time. We wean them down as low as we can go, and then we try other modalities of treatment. You know, there's lots of studies that look at Alexander technique, yoga, acupuncture, acupressure, good physical therapy, regular exercise that make people stronger and healthier again. And we need to work on that. And that stuff needs to be funded. It needs to be researched as well. The way that people usually start abusing drugs is somebody, 70% of the time it's a family member or friend, gives them a pill. And this pattern of behavior, I see it all day long. People say to me, somebody gave me half a Klonopin, it made me feel better. Can you give me some Klonopin, doc? And I think to myself, what kind of friend or family member is handing you bottles of pills? Like, why is that okay? Do they have a medical license? Are they a pharmacist? It isn't okay to be using other people's pills. And it isn't just actually the children, the 17-year-olds and the 22-year-olds, but it's their parents and their grandparents who need to be retrained to think to themselves that, first of all, if you have a bottle of pills in your house that is a controlled substance and you're not actively using it right now, it needs to be destroyed. Today was just a normal work day for me. I saw brand new baby at the hospital who was 12 hours old, and I saw a 96-year-old patient at the hospital, and I saw hypertension and diabetes, and I saw 8 people under the age of 25 with heroin addiction. And interestingly, they all tell me the same stories, right? They started with the pills when they were 15 or 16. It didn't take long before the pills stopped working, and they realized that they could buy heroin anywhere in Franklin County at this point, much easier than they could buy alcohol. And at this point, with much greater ease than buying the pills have become very expensive and the heroin's very cheap. And the problem with this drug is that it's buyer beware, because you don't know what you're getting when you buy a bag or a bundle of dope from anybody, and the dose that you took yesterday, the same dose today, could kill you. Having said that, there's a window of opportunity here because people are scared. A lot of people with addiction on the streets right now are very, very anxious about the quality of the heroin out there, and they don't want to die. They don't really want to have this disease at all. They actually want to be free from this disease. They don't want to be actively using heroin. They want treatment. And we live in the most rural, the poorest, the most agricultural county of the 13 counties in Massachusetts, and there's not a lot of treatment options here. That their closest intensive outpatient substance abuse program to Franklin County is down in Northampton. The window of opportunity, when somebody walks into you and says, I need help now, you got about 3 hours before they're going to go back out and use. They're going to start withdrawing soon, they're going to start craving the drug, and they're going to be back on the street. You have a small window of opportunity to get them into treatment. And one of the problems is that we spend hours and hours on the phone, case management in every hospital, case management in every ER, desperately trying to find a bed. You can't tell me that there's not a way to develop a technology, an app on your smartphone that can track every bed in Massachusetts and its status, whether it's available or not, whether it's impending or not, is it a red light, a green light, or a yellow light? You can go to Google in Boston and just task somebody in a week to make an app that can track every bed that is licensed by the Department of Public Health in this state, so that they are mandated to keep us updated every 30 minutes when a bed is available. Why are we using telephones to call the Brattleboro Retreat to find out if beds are available? I think that's crazy. What would it take to open up beds at the hospital again? What would it really take? We have doctors on staff, we have nurses on staff, we have beds available. We need treatment plans. And again, I'm not a firm believer that the only way to get clean and sober is an inpatient hospitalization. I really do think we need long-term outpatient sober living. That doesn't involve a hospital. Hospitals are expensive. It's not that outpatient long-term sober living is all that cheap either, but compared to the cost of the addiction itself, it's fairly cheap treatment. You know, I have an issue with opiate treatment because the treatment's complicated. You know, people are not sober probably ever, right? They're fighting this demon on their back. And we see this with Philip Seymour Hoffman. Here's a guy who had addiction, really battled it down when he was age 22. 23 or 24 years later, he relapses, and a year after that, he's dead. People who battle opiate addiction, alcohol addiction, it is a struggle for the rest of their lives. And the notion that you could take a person and put them into a 3 to 5 to 7 day detox and then ship them out to their streets and have a sense that somehow they're better, that's crazy. I don't know how that actually helps anybody. And in my experience, I have very few people that come out of detox and are truly improved. The truth is they're out on the streets, they're jonesing for the drug, they're weaning off of methadone or whatever they were given. Detox beds cost a lot of money, and I actually think we have to think of a new way of helping people get sober. We need an intensive outpatient treatment program here in this county. We need long-term sober living here in this county. When I say this county, you know, you go 4 counties surrounding us every direction before you get to any sober living. This is a vast area without a 90-day, 180-day, or a year-long 6 to 12-month bed available to us. So we're covering a vast territory without any detox beds or any sober living beds. This is actually a really smart community. There's tons of great mental health people here. There's tons of people who've been living sober for decades who have a lot to give back. And the peer-to-peer work that people do is critical. I think we need to activate the community and get more people involved in helping people stay sober. I'm a big believer in exercise and sobriety. The Exercise is Medicine program at the Y has done a wonderful job of taking people with addiction and getting them to work out every single day with other people who've had a history of addiction and help them lead sort of a really good, healthy lifestyle. Help them actually to experience their bodies and the pain of joints and muscles again, because for so many years they felt really nothing. Drugs numb you to everything, every emotion possible, good or bad. So right now, the one place to get clean and sober in Franklin County is the Franklin County House of Corrections. So that's unacceptable, that the only place I can safely send a 22-year-old tonight is to jail. Jail is not the best place for an addict to be. Having said that, I'm actually always grateful to the courts and to the sheriff's office because they are an extra layer of pressure that help people stay sober. My people that do really well often have jail hanging over their heads. And the probation period, the probate court, all the work that drug court has done is much heavier of a hammer than what I carry to help keep them straight and sober. One of the problems in our community is there's a sense that if you have a problem, there's a pill to fix it, whether you have pain or whether you have anxiety or whether you are suffering with inattention, that there must be a magic medicine to fix all problems. To be honest with you, that attitude has to change. In summary, what I need to say is that I'm an urban trained doctor from this rural area, and I could tell you the problem here is not any different than it was in the South End or in South Boston or in Quincy. It's much the same, except we have no resources. We have very few opportunities for our kids. The distances that people have to travel to get to places are enormous. And there's no public transportation that's truly accessible. So an equivalent problem, fewer resources, greater geography, greater poverty. And it's left us with a real crisis.
What an extraordinary community resource. Wonderful human being, too. Chris Donnellan is a former police officer, probation officer, and legislator. As sheriff of Franklin County, Chris has provided the leadership to create many innovative and significant initiatives to help the inmate population get an education, develop job skills, and with behavioral programming. Most recently, the post-released housing reintegration program that is partnering the Greenfield District Court Office of Probation and the Greenfield Housing Authority. He continues to be on the cutting edge of our justice system with programs that look to reduce recidivism and have for his entire career, regardless of his position, been committed to improving the quality of life for all residents in Franklin County. Ladies and gentlemen, Sheriff Chris Donnellan.
Thank you very much. Thank you, Bob. Thank you, all of you, for your presence here today and your willingness to learn, contribute, and be a part of a solution. For many months now, something disturbing has been happening in our rural community. We once thought we were immune to big city problems, but now we are painfully aware that no one is immune. I would like to thank my friend and colleague David Sullivan for his work with us in this task force. Although David and I have made it very clear that we will be aggressive in pursuing and prosecuting drug dealers, we also are united with John and this whole community in our belief that addiction is a disease. People should not be strapped with a criminal record because of it, and we need to build an infrastructure of treatment in this state so that getting arrested and sent to jail is not the only way to detox and get treatment. We have seen a very aggressive progression of opioid addiction in our community, young, old, some intentionally, some completely unsuspecting. It is here, and it is killing our young people. We see it in increased crimes, from breaking and entering into cars and homes to convenience store and bank robberies. These have become part of the scene in Franklin County, soon after the overdoses started. The purpose of this task force is to bring attention to this crisis, educate our neighbors, and find help for those afflicted. We are joined today by elected leaders who have already stepped up to advance our work, judicial leaders, and problem solvers and collaborators who want to partner with us. They are willing to care and determined to save lives. Our first speaker today is Senator Stan Rosenberg. Senator Rosenberg and Representative Kulik just recently succeeded in securing funds in the state budget for our task force to hire a coordinator so that our thoughts can be turned into actions. And hopefully our actions can be shared with other communities in Massachusetts. If you have read the Globe, you know that Cape Cod and Taunton and the North Shore are all dealing with similar problems. The Massachusetts Senate, with Senator Rosenberg's leadership, is now hearing testimony across the state on the scope of the crisis and steps to respond. Senator Rosenberg has been our senator since 1991. He has served in many leadership positions in the Senate, including Chairman of Ways and Means, President Pro Tem, and Majority Leader. This past year, he received the greatest honor any member could achieve when his fellow senators in the Democratic caucus announced their support for him as the next Senate President. Despite Senator Rosenberg's unprecedented success at the State House and across the state, we still refer to him as Stan. Please join me in welcoming Senator Rosenberg.
Well, thank you very much, and thank you for inviting me to participate in this forum today. I think the presence of so many people and the fact that it's an overflow crowd says it all. This community is deeply concerned about the loss of life, about the loss of the potential for young people and people of all ages, but especially young people who are being affected by this epidemic. I would like to first ask that we just take a moment of silent reflection and focus for a moment on those who have been lost to this epidemic and to those who have no one to remember them, so that their lives will have meaning as we work together to try to address this huge problem here and across the Commonwealth. Please hold these people in your hearts and your minds in the days and the weeks ahead as motivation and reminder of why we're gathered today and why we will keep gathering until we solve this problem. The second thing I want to say is that, as Sheriff Donlin has indicated, this is not a Franklin County problem. But people here in Franklin County have to work here to take care of our own. There are meetings going on all across the Commonwealth in places like this because the same problem is occurring in their neighborhoods, in their communities. So let's join together here through the task force that's been formed and through whatever other mechanisms we can find so that we work together to solve this problem here and share what we learn with others and listen carefully to what others are doing elsewhere so that we can, all across the Commonwealth, we can address this problem as quickly and effectively as we possibly can. We cannot afford to keep losing young people and losing the potential that they have for meaningful and productive lives contributing to our communities. The second thing that I want to say is that I could not agree more with the governor when he said on Monday at UMass Boston that drug addiction is an illness, and we must begin in Massachusetts to deal with it as an illness. There are some very specific things that we need to do, and we just heard in the video the fact that the principal mode of treatment at this point is incarcerating young people as a result of addiction and this illness. And as hard as the sheriffs work, the resources they have available to them and the environment in which they operate is not the best place to treat an illness. So we need to redouble our efforts in this county and all across the Commonwealth to ensure that there are adequate and appropriate beds for treatment everywhere, and that no one should be found waiting on a waiting list to be able to get the treatment that they need. The professionals tell us the window is very narrow from the point of recognition of the need to seek treatment and to get the treatment and to getting into that bed and into that program. So we have to work aggressively to ensure that every individual who is caught up in this problem has a facility, an opportunity, a program that will meet their needs to be able to address the problem. The information that we have now is that both the federal and state insurance programs serve as a program of last resort, but because they do not pay adequate rates, the number of beds available to people who come into the system through public insurance are inadequate. We need to change the reimbursement rates in order to ensure that those beds are available no matter what insurance you come with, because if you happen to be in a public program and that is your health insurance, you should have equal access to those beds. We need to increase the number of beds, and we need to work for a time when we don't need the beds, but we need the beds and we need the programs, and we need them as quickly as possible. So my colleagues who are here today, I saw Denise Andrews and Steve Kuliksaid is here, and Representative Paul Mark, and everyone else. We all have to make this a budget priority this year to really work to try to get programs in place here as quickly as possible. But we should also try to prevent the problem as well. And there have been successful strategies in the past which have faded away over time for different reasons. So maybe they were not as effective as people thought, or for whatever reason people decided to let them go. Then they need to be replaced with programs that will be effective so that the community works together to prevent the next person from becoming addicted. And it's not enough to just treat the problem when it appears. It's our job collectively to help people understand just how dangerous these substances are, how quickly you can become addicted, and how difficult it is, as was said in the video, to rid yourself of the problem, and many people apparently live with it for their entire lives. So better to prevent it than treat it, but once it appears, we need to have treatment. Several things are going on in the legislature right now that you should be aware of. In addition to funding the task force here in the county, the Senate has launched a special commission that is now traveling the state collecting public testimony on the experience that families and individuals and communities are having collecting information from professionals about what we can do about this, and we are expecting a set of recommendations in time for the Senate budget debate, and I'm hoping that there will be real-time communication so that our friends in the House can also be benefited by the public testimony that's coming forward. This is a time not for rhetoric and long speeches. It's a time for getting down to business and figuring out what we have to do and getting to do it. Representative Hunt and Representative Rushing have both offered pieces of legislation which are now moving through the process. They've both recently come out of committee and will be considered, I hope, on the floor of the House soon. One of them seeks to identify best practices inside criminal justice facility, that is the jails and houses of correction, and the other best practices on the outside in the community, and has the Department of Public Health serve as the provider of last resort, so that if all else fails, it would be the responsibility of the Department of Public Health to ensure that there are enough beds in the Commonwealth adequately funded so that people do not have to be on a waiting list and can go right into the program that they need for their service, for their treatment, rather. And then two other points that I would raise, and one is a missed opportunity, and I raise it just because sometimes you need to think about the consequences of actions even if they happened a while ago. Unfortunately, 2 years ago, I guess it was, the legislature approved expanding tax onto the sale of certain alcoholic beverages, which was then repealed by the voters. That money was specifically earmarked for substance abuse prevention and treatment. As voters, we have the right in this state, and we have the responsibility in this state, to vote for the people who make the laws, and sometimes we have the opportunity to vote to repeal those laws. A lot of people look at those ballot questions very casually and don't think deeply enough about what they actually mean. It takes a lot for a legislature to vote on taxes. It takes a lot, especially on things that are popular with the public. I regret so much the fact that that tax was repealed, because it was the funding source and would have been in place to have programs in communities across the Commonwealth that now don't exist. That's not an excuse. It's just an observation. We have to find the money in this upcoming budget so that we can create these programs. But I would point out that there will be other questions on the ballot, and there's a few that people are already musing about. And one of those, if it gets to the ballot, is going to create a substantial amount of money, and we ought to commit ourselves to make sure that that money is significantly dedicated to this problem. And we'll know in a couple of years whether that will happen, but we can't wait a couple of years. We have to get to it now, and I hope that my colleagues and I will be able to be productive for this county and for the people all across the Commonwealth in securing adequate funds to get programs open with reimbursement rates that are adequate to support the programs and the efforts. So I've sought to give you a little bit of an outline of what we're working on in Boston, even as you work here in this community, this county, to address this problem. Our doors are open, our ears are open, our hearts are open. We want to hear from you, and as you come up through this task force that you're working with specific ideas, needs, proposals, please make sure you get them to us in real time. Let's not wait for final reports. We need action, and we need it soon. Thank you.
Thank you very much, Senator. There are differing schools of thought when it comes to appropriate activism within our judiciary. Some judges are very uncomfortable with it. In Franklin County, we are fortunate to have a history of jurists who realized that the court must be flexible enough to serve the needs of the community within which it resides. That's when it becomes a justice center. The Chief Justice of the trial courts understands the concept of justice centers. Chief Justice Paula Carey has distinguished herself within our state's legal community, focusing much of her time in the area of domestic relations. She served on the bench in the Probate and Family Court, was the chief of the Probate and Family Court, and was appointed this past July as Chief Justice of the trial court. We are grateful for her presence today as we work with her to make sure the trial court is a part of our whole community solution to addiction. Please join me in welcoming the Honorable Paula Carey.
This really is standing room only, isn't it? It's my pleasure to be here today, although unfortunate that we're here to talk about this, what I call a public, and I think most of you in this room would probably call it a public health crisis. It threatens us in ways that perhaps those of us in this room appreciate, but I think many in our community don't appreciate. It threatens truly our public safety and compromises our quality of life. Heroin is a drug that does not only grip those born into poverty, but it affects individuals of every socioeconomic and educational level. As a court system, we are increasingly aware that we can no longer simply adjudicate cases and call balls and strikes. Instead, we must view each individual holistically as they come to us and really address the underlying issue that has caused the behavior that causes them to be before us, often some sort of criminal behavior, but the underlying issue is really some sort of substance abuse issue. We recognize as a court system that we can't do it alone. We need your help. This is a challenge that really requires the collaborative effort of DPH, DMH, police chiefs, district attorney, defense counsel, local providers, and frankly, the community itself. Well, the court administrator, Harry Spence, and I just went to Greenfield earlier today, and the chief probation officer described to us a situation where she has herself, as the chief the chief probation officer, an assistant chief, and when she first became chief, she had one PO. But parents would come to her and basically bring their child to her and say, help me, I don't know what to do. Now, this individual hasn't committed a crime. They haven't done anything that would cause them to be before the court. But yet, our probation officers step up. They step up to help these individuals, and frankly, they're on the phone. The doctor, as she talked about a computer system that might automatically help us identify beds, really resonates, because often our probation officers sit for hours on end trying to find available beds for these individuals. It's not easy. What the court is trying to do is we have actually added to our budget request a module for specialty courts. Massachusetts is very much behind nationwide other states with regard to drug courts, mental health courts. What we're proposing is 8 drug courts. Some may end up being regional courts as we begin to roll out further intensive efforts to address the issues of addiction. We have programs, you're going to hear about the HEAP program in Woburn, which has saved countless young people from the demons of addiction and really made a difference in the communities in the North Shore. Hopefully, this new task force here in Greenfield and Franklin County will help in the similar types of ways. So in recognition of the fact that we've got a serious problem, the trial court has undertaken to advance some of our mechanisms. In fact, I just had a conversation. The district court now has an individual who is a judge, but she manages, and she's with us today, Judge Hogan Sullivan. She manages all of our specialty courts, and she looked at me today and said, you know, I think we need to do things differently, even broader than what we're talking about doing, because this is such an overarching, not just in the Commonwealth of Massachusetts, it's an overarching problem nationwide. But we'll bite the Commonwealth off first, and then maybe stretch ourselves a little bit further. Anecdotally, what I've heard from district court, primarily district court judges, is that 90% to 95% of the people that come before him or her, are addicted, that they have substance abuse issues. For us to ignore that, incarcerate them, which we know, the statistics tell us, that that's only going to make things worse, and that individual is going to come out of prison worse than when they went in. We're going to have increased recidivism rates and also increased jail time. In fact, when Court Administrator Spence and I go to speak with legislators about our specialty court module, we're promising, he and I both have a difference of opinion about whether we'll be able to have the data in a year or whether it's going to take 2 or 3 years, but we have indicated to legislators that we'll come back to you and we'll show you the savings to the Commonwealth, setting aside whether it's the right thing to do for the individuals that are before us, but we'll show you that we can save money for the Commonwealth by reducing jail days and reducing recidivism. The trial court has really made establishment of these drug courts a priority. But our request is not merely for the trial court. We've actually come up with a unique idea in working with the Department of Public Health and DMH. Primarily, the monies are for beds and for clinicians. The trial court is only looking for probation officers. That's all we're looking for in terms of our budget funding, because we can't do it ourselves. For us to operate and try to operate without DPH beds and without clinicians, it would be an empty promise to the individuals that we try to serve. And we also have a component for veteran services. We don't expect that we'll have a veterans court in every community, but we expect that we'll have veteran services for those who need it, because our veterans come back to us in very different ways that we need to really truly appreciate. Many have substance abuse issues, many have mental health issues, and they have given their lives and taken themselves away from their families to serve and protect us. So we owe them a duty as well when they come back. We know that when an individual comes to our court because of an arrest, we have a brief opportunity, a really brief opportunity to try to help that individual accept services. It's a window. As discussed earlier, it's really a short window. And if we can't find them the help, if we have to wait days to get them into some sort of treatment, then we've lost that opportunity. We've lost the opportunity to help that person get on their way to becoming a more productive parent, a more productive worker, a more productive member of our society. This is tough, but it's about getting those who are desperately sick and giving hope to those who wish to get better. To those of you who have embarked on this amazing journey, an amazing work to really make a difference collectively as a community and beyond, I'm going to leave you with one of my, because this won't be easy. You'll suffer failures. You will lose people, unfortunately. But I have a favorite story that fits a lot of circumstances, but I can't think that this has got to be one of those circumstances. And it's actually a book that was written, and it's been turned into a short story written by Lauren Isley. And it's called The Starfish. I usually add a little bit of my own twists to this story, but it's about an author, and this is an author who needed quiet time to be able to do his work. So he would go to the beach and do his writing. He had a cabin on the beach. So one morning he got up and he walked down the beach, and he saw this figure way in the distance, and he said, "Oh, isn't that interesting? There's someone who's decided to dance. They're dancing on the beach." As he got closer, it was a young man. And he couldn't figure out what he was doing, but he was picking something up on the beach. And he couldn't figure out what he was throwing it into the ocean. And so as he got closer, he realized that there were a lot of starfish all over the ocean, all over the beach. And this young man was reaching down, picking up the starfish and throwing them into the ocean. And the writer went up to this young man and said, "Young man, look at all the starfish. What are you doing? They're all over the beach." And he said, "Well, the tide is going out. I need to throw the starfish into the ocean." And the author said to him, "Well, how could you possibly think that you could make a difference? How could you think you could make a difference? There's too many of them." He reached down, he picked up a starfish and threw it in and said, "I made a difference with that one, didn't I?" So, stay strong, stay committed. We're going to win this fight, one person at a time. Thank you.
Thank you very much. I first met Harry Spence when I was a member of the legislature and he was Governor Romney's commissioner of the Department of Social Services. He has a reputation as a reformer, a man with high expectations when it comes to the way government should serve the people. In his new role as the first ever court administrator for the Commonwealth, he has already made monumental progress in making our court system more efficient, effective, and most importantly, collaborative. Administrator Spence has visited Franklin County many times, and his presence today is yet another signal that our courts are here to partner with us in this effort. Ladies and gentlemen, please join me in welcoming Court Administrator Harry Spence.
Thank you, Sheriff. These days, if you invite either the Chief Judge or myself, you usually get both of us because we do everything together these days. There is joint leadership in the trial court. And my task, somebody said to me earlier, "So what are you going to say today?" And I said, "Well, I'm going to wait and hear what Chief Carey says, and then I'll fill in whatever she forgets or doesn't include or expand on that." So let me just add a few notes. First of all, I think we in the judiciary are extraordinarily proud of the leadership that John Merrigan provides on this issue in this community, as on many issues, but in particular on this issue. Deeply proud of John Merrigan, his family, for bringing their own experience to bear and making of that experience something of huge community value. That's an extraordinary act. That he's partnered with D.A. Sullivan, also a former register of the trial court, and Sheriff Donnellan just indicates the quality of leadership that you have in this community, as was the presence of our future soon-to-be Senate President, Senator Rosenberg. So on the one hand, this is a very hopeful moment. There is extraordinary leadership locally and in the state, in Senator Rosenberg and in the legislature, and that is a hopeful moment. On the other hand, it's a hugely frustrating moment. It's frustrating from my point of view because we in the trial court are just emerging from a period of huge crisis. We lost almost 20% of our staff in 5 years. And so you heard the Chief Carey mention the fact that at one point there was just a chief probation officer and one probation officer in the court. We're back up to 6. But in a moment of crisis like this, you obviously wish we were further along on the rebuilding. We wish we could be further on the rebuilding. Those 6, and I know our extraordinarily able chief probation officer in the district court and very able chief probation officer in the Superior Court are doing everything in their power with the limited resources available, and we hope to make more resources available. So that is a frustration. I'm frustrated that we don't have more drug courts in the state, though I'm awfully glad we have one here in Greenfield. We are, as the chief said, we are among the 3 lowest states in terms of the incidence of drug courts. We hope to correct that in a 3-year period to double the number of specialty courts in Massachusetts and get us to a standard, the right standard, which is double the current number of specialty courts, so that we can better serve all of the population of the state, whether it's urban or rural or suburban. Anyone facing a drug challenge will have a drug court available to them. I must admit, pleased that Dr. Pote, I think it is, referenced the fact that drug courts bring tools to bear a certain amount of compulsion that sometimes is hugely valuable, often is hugely valuable in helping someone break the habit of drug addiction. Candidly, I have a brother-in-law who I only wish and pray would one day get into a drug court and get 18 months of consistent supervision, because he has never had that long period of extended supervision that's so essential, I think, or so at least can be so essential to breaking an addiction. So those are the moments of the things of hope, of the leadership, the frustration about the resources. The interesting thing about leadership and frustration is it often, where there is leadership, frustration leads to solutions. It leads to creativity. It leads to addressing the problem. The presence of all of you here is a mark both of frustration and determination. Your own individual leadership, leading by coming here today, setting an example for your neighbors, taking to them all the knowledge you gained today, all the commitment and determination that you gained today, and sharing it across this entire county to address this problem. So I am in that sense, proud, frustrated, hopeful. Hopeful that with determination and will, we can in fact address the terrible problem that is challenging this community today, that's challenging the Commonwealth, that I actually believe is challenging the nation. So I am always proud to be part of a Franklin County effort, because you also set a model for collaboration, for common commitment. We in the East, we fight about all sorts of things that you manage somehow to resolve among yourselves and move forward on. We could all learn something from that. So that's the lesson I keep learning every time I come to Greenfield. I look forward to, with hope, to the solutions that together we can shape in the coming months and years. Thanks.
Hillary Jacobs is the director of the Bureau of Substance Abuse Services. She has spent her professional life in addiction services. I don't think anyone in state government has a better grasp of what we are going through in this community than she does. Her experience in outreach, detox, clinical work, and counseling services will be invaluable to us as we move forward with the work of our task force to the next level. We all look forward to working with Hillary and continuing to seek her guidance and assistance. Please join me in welcoming Director Hillary Jacobs.
Good afternoon, and thank you very much for inviting me here today to discuss this important topic with all of you. I'd like to thank the Greenfield Community College for hosting the event and all of the legislators in attendance for their interest in the problem, the trial court and law enforcement people in the audience, the members working with John Merrigan, and others in the opiate task force bringing awareness to the problem, and treatment providers. I'd also like to acknowledge the members of the community who have experienced overdose of family members firsthand, including those who have lost their lives to this disease. I am truly sorry for the losses that you experience. I think that it really speaks volumes about what's needed to address this problem, that all these different kinds of people need to be in this audience to really come together to work on this problem. As we all know, addiction affects all of us, and the opiate problem is epidemic across the Commonwealth. In fiscal year 13, approximately 59% of the admissions to BSAS, that's the Bureau of Substance Abuse Services, to BSAS treatment programs were from people reporting either primary or secondary opiate use as their drugs of choice. One of the ways that addiction really differs from other chronic illnesses is that less than 2% of people who have addictive disorders report that they see a need for treatment. This is not like anything else. So if you got diagnosed with cancer, I think it's safe to say that 99% of us would see a need for treatment. And this is a really difficult disease in the way that it's different, in the way that it changes people's consciousness and judgment around what they need. When we look at the opiate epidemic at the Department of Public Health, we basically have a 4-part strategy. We are interested in stopping people from getting prescription medicines that they may not have a medical need for. Dr. Pody talked to that to some degree. We are interested in providing help for someone if they become addicted to prevent sickness, injury, or death. We want to treat addiction and save lives. And we need to provide recovery support to both people and their families. We've made some progress on these fronts. We're not very good at letting people know what some of the things that we have in place are and what some of the progress has been. So, and it's important to look at this as we need to address this problem in 4 areas. We need to do prevention, we need to do intervention, we need to provide treatment, and we need to have supports in the community for people when they're finished with formal treatment so that we have healthy communities for people to maintain their recovery in. So in terms of prevention, we obviously offer training on overdose and prevention and education for all addiction treatment providers. We fund prevention coalitions to address underage drinking, prescription drug use, and opiate overdose. One of the things that isn't as well understood is that the younger you are when you begin to drink alcohol, the more likely it is that you will have a substance use disorder in your lifetime. So when we start at the place of preventing prescription drug abuse or opiate use, we've already skipped a really important beat. We really need to start at recognizing the role that underage drinking plays in the later development of substance use disorders. We also require prescribers to have educational programs on pain management and being able to identify addictive disorders. We have located drug take-back boxes in over 100 communities for residents to return drugs to their local police station. We collaborate with 91 communities across the state to prevent opioid abuse, use, and overdose. There is a lot of work going on in hospital emergency rooms, in school-based health centers, and in other healthcare settings to provide screening, brief intervention, and referral to treatment for those people who are at risk before they fall over. And we have a lot of educational materials on our website. In terms of interventions, probably the most well-known intervention we have is the distribution of nasal Narcan or naloxone. That is available all over the state. We provide Narcan to people who may witness an overdose. That can be anybody, a teacher, a friend, a parent. And we have enrolled over 21,000 people in that program since it started, and we have documented 2,500 overdose reversals where people's lives were actually saved. Yeah. The Good Samaritan Law allows people to contact local law enforcement without fear of arrest in the case of an overdose, which does a lot to make people call and get help for the people that they're with when they are overdosing. And we have a really robust treatment system. We hear a lot about how we don't have enough, but I'd like to put that in some kind of context for you. Massachusetts ranks 6th in the nation in terms of how many treatment admissions we have per 100,000 people in the population. So we have a pretty robust treatment system. Unfortunately, we have a bigger addiction problem. When we look at recovery support services, we have, there's a parents group that the Bureau partially supports called Learn to Cope, and they have support groups all over in different places in the Commonwealth for family members for people who have substance use disorders. We have community-based recovery, peer-led recovery support centers. There's the Recover Project in Greenfield. There's actually someone from the Recover Project in the audience. He's clapping. And we enable, and we also have some recovery high schools across the state. So those are the kinds of interventions that we have. We need more of them. We need them spread out throughout the state, but these are the things that we are working on and the things that we have. You know, and despite this work, the problem persists, and it requires all of us to come together to solve the problem. I think that as we were talking about the robustness of the system, but yet the system still not always being able to provide treatment on demand, towards this end, the governor and the legislature have provided us $10 million to expand beds for the involuntary part of the system, the Section 35 part of the system. That added 280 new beds to our residential, 200 beds to our residential system and 80 beds to what's called transitional support services. Although those beds are dedicated for people who have Section 35, it helps there be flow in the entire system. It helps everybody to have those additional beds. And this year, the governor has added an additional $1.3 million to our budget to add 64 additional beds, a new public detox, and a new step-down service from detox, which again will certainly help. And as Chief Justice Carey talked about, there's also additional funding from the governor in the trial court budget that includes within it additional beds for the Bureau of Substance Abuse Services. So there's no easy or one answer to this problem. However, I'm confident that together we will be successful in preventing opioid addiction and the problem of overdose. Treat addiction, save lives. Thank you.
Thank you, Director Jacobs, and thank you to all of our panelists, or all of our presenters who spoke here this afternoon. We're going to take a short 5-minute intermission. You can stand up, stretch your legs, get a cup to drink while we set up our panel for the next phase of the discussion. Thank you.
Look around the world and see our families dying. Doesn't seem to matter all the things we're trying. Another needle in the arm is just a message. Another day is coming and it's time for healing.